It's not the most recent work.
No.
Okay. Okay, yeah. No, my contact with hemato-oncology was as a patient. You know, I think from the clinical side, hemato-oncology really has changed dramatically. So the malignancy I had, something ultra rare. I was diagnosed with 6 known patients on the clinic. None of them had survived more than 11 months. Patient 7, I've been cured for 15 weeks. Classic chemotherapy. Oh. But these very new schemes that came up at the time, and after a couple of induction cycles, can do these ultra-high doses of chemotherapy. Basically, at 9 to die, stem cells.
Nemám to u sebe.
Vážně. Nenosíte na potkání.
Many patients survive.
Yeah, actually, there is a 2% chance to die from the treatment. And that's, if we talk about dying, 2% is a pretty high chance.
It's a pretty high chance.
But basically, if you survive the treatment, more or less certainly you're cured.
Yeah.
And that's something very few other malignancies can say. Although I wonder whether in a room of this size you need 2 screens. I mean, in these big lecture halls, as big conferences where you have 1,000 people in the room, that's useful, but in this room it seems a little overkill.
You know, it's a room where the scientific board meets, dean's advisory board meets, so it's like the VIP room. It's normally, this room is not used for receptions.
Yeah,
so
I
it's
figured.
kind of backup room like you, but otherwise no regular lectures are assigned to this room.
Therefore, the desks are in good condition.
Mm-hmm. I noticed that.
These are deans of
Those are historical deans of our faculty. The most recent deans are there is a small rooms with some chairs as well, but those are the old ones.
So, start.
Yep. Let's close the door.
Ladies and gentlemen, it's my great pleasure to welcome here in Prague Professor Michel, who is professor of pharmacology at the Johannes Gutenberg University in Mainz. And he will give the lecture on experimental and clinical studies that have the connection to muscarinic receptors in the professor.
Thank you for the introduction and the chance to visit this very, very old university. When we initially discussed of visiting, obviously I thought visiting him, I should talk about muscarinic receptors, although I must admit most of the studies I will be presenting were done like 10 to 20 years ago. But I still think there are some interesting ideas in this that transcend what was done at the time. I first would like to mention several companies with whom I collaborated on some of the projects, although except for the first one, I didn't get any money in the last 15 years. But just at the time the studies was done, they were, at least in some cases, funding my lab or paying me consultancy honoraria. I think disclosing that is a very important thing. I want to talk about three aspects, being the physiology of the bladder, the pathophysiology of the bladder, and then clinical treatment effects, and of course, all of this in the bladder. So let's start with the physiology. And for me, I think it's the most logical step to start with which muscarinic receptors are present. And we ourselves have only done very little work on the expression at the mRNA level. So I did a little search in preparation of this lecture and was really amazed that there is no strong consensus. Many studies in the field have looked at the presence of 1, 2, or 3 of the 5 muscarinic receptor subtypes, but very, very few at all 5. And then some studies used whole bladder, some used just certain cell types in the bladder. So that gives it a difficult thing. One of the themes that will be recurring throughout the presentation is talking about sex and gender differences. And the lower urinary tract is a part of the human body which shows a major sexual dimorphism in the anatomy. You can see here, the big difference is that, well, the males have a penis. Well, I guess you knew that. But that makes a big difference. The other relevant difference is males have a prostate. And when the urine is stored from the bladder and then, under socially accepted circumstances, is voided, there is fairly limited resistance in the females, whereas the urethra is much longer and surrounded by muscular tissue, which dynamically can create resistance. And that the prostate also has a lot of muscle in it. And especially when the prostate in elderly males becomes larger, that further increases, and that's potentially driving some of the bladder problems in older males. So generally, as I said, looking at the mRNA level, there is no strong consensus data, but it appears that M2 and M3 are most prominently present at the mRNA level in both rats and humans. If you look at the protein level, and we have primarily done this with radioligand binding, because even until today, most of the muscarinic receptor antibodies have very, very poor selectivity. And in the beginning, we did this with compounds that by today's standards are not very selective. But you can already see here, both in the pig and in the human dechuser, that this seems to be largely an M2 population. What you would expect for an M2 receptors is inhibition of cyclic AMP formation. And when we tried that in slice preparations of the rat bladder, we saw very little of that, both in male and female. And as positive control, we saw at least a little more with an alpha-2 agonist. I don't know where the label went. Anyway, however, we saw a very substantial increase in nodular phosphate formation, a response typically mediated by M3 receptors. And indeed, an M3 antagonist was much more potent than an M2 antagonist. And that was the same in both males and females. And by and large, male and female rats had a similar abundance of G protein alpha subunits. In line with that, we found, and many others found that as well, that the diffuser contractions in various species, including rats, pigs, mice, humans, occurs predominantly, if not exclusively, via the M3 receptors. And that had been surprising to many, because if there is like 80% M2 receptors and only up to 20% M3 receptors, that these M3 receptors mediate almost exclusively the contraction responses. I showed you that we have inositol phosphate formation via M3 receptors, and we know that phospholipase C is the prototypical signaling mechanism of M3 receptors, and contraction occurs via M3. So it was a general consensus that, hey, this inositol phosphate formation is what mediates the contraction. And that was shown in figures like that in textbooks, in review articles in the New England Journal of Medicine. And we noticed no one had ever tested that. It was just the conclusion, which was highly plausible, if they couple to phospholipase C, and if it's M3, then the contraction must be phospholipase C mediated. And when we then did experiments on that, and we in this case is Tim Schneider, who was a urological resident at the time, and Mariana Fleischmann, a young scientist from Russia, and they jointly worked on this project. And you can see here, even in fairly high concentrations, a standard phospholipase C inhibitor, U73122, didn't do much, especially if you compare it to vehicle time controls. And we hardly could believe that in the beginning. Said, are we doing something wrong? Are we indeed inhibiting, in these concentrations, phospholipase C? And so we did additional experiments where we again stimulated inositol phosphate formation with carbachol, and that was completely suppressed by the phospholipase C inhibitor, as expected. But in the same concentration, it did nothing to the maximum response or the potency of carbachol. We looked at a whole range of signal mechanisms, both in the proximal pathway and in the distal pathway. So we looked also at phospholipase D, at phospholipase A2, at cyclooxygenase, or at receptor-operated calcium channels, and none of them really seemed to play a big role based on the inhibitors indicated here. However, inhibitors of voltage-operated calcium channels, such as nifedipine, had an effect we found to be really surprisingly strong. So at about 100 nanomolars, we already got a more or less complete suppression of contraction. And you can see this is really not affecting the potency, but is a concentration-dependent effect on efficacy. We went one step further, and that was mostly the work of Marina Fleischmann. The proximal work had been done by Tim Schneider, and looked at various protein kinases. and found again very little effect for inhibition of PKC, which is a downstream target of the phospholipase C pathway. We found very little effect of a tyrosine kinase inhibitor, of PI3 kinase inhibitor, and of inhibitors of extracellular related kinase. However, Rho kinase, which plays a major role in the control of smooth muscle tone, did play a major role. And as you can see here, it concentration dependently reduced the responses. And in this case, it was a reduction both in the potency and in the efficacy of time-matched vehicle controls. I should say the data I'm showing you here are from rat experiments, but we did, for those compounds that we found most surprising and those that had a lot of effect in the rat, we also did a study on human samples and basically got identical results. And then something interesting happened. There was at the same time a group in Philadelphia in the United States headed by a guy called Michael Ruggeri, Italian by ancestry. And they published just a few months later than we in the very same journal, the Journal of Pharmacology and Experimental Therapeutics, an article where they said, nope, we think that is phospholipase C. And I think what happened then has an important lesson for us as scientists, but also for society at large. So what did we do? At the next meeting we both attended, we went to a pub and had a beer. I'm happy to admit it was more than one. And we discussed the matter and said, how can we explain that? We both trust each other in our work quite a lot. So there must be an explanation, and that explanation may be interesting. And we decided to run a study, and they had used somewhat different protocols, and they had used different inhibitors than we had. And we decided to run a study where Michael's lab used our drugs in their protocols, and my lab used his drugs in our protocols. And we made an a priori decision, no matter what the outcome is. We will write up a shared paper. And we decided whoever's lab was right, that student will be first author, and whoever's lab was wrong, that boss will be the last author. And it turned out that we had been right, which may have been pure coincidence. And we found that the tools he had used had some non-specific effects that explained his finding. And we were later validated by other groups that unisono found PLCs not involved. For instance, also in mice or in cats. So when we then submitted this paper together, at the time, it still was that you submitted a paper on paper. And we wrote a letter to the editor, co-signed by both of us, said, both of our labs have published in your journal completely opposing views, and we decided to settle that jointly, like gentlemen, and here is our consensus report. May the literature be cleaned of misinformation. And the editor was really amazed. He had never experienced that before. The two groups originally publishing opposing data agreed to put together and then write a consensus paper based on new data, seeing where the controversy came from. So that paper was accepted in no time and took less than a week. things we have been interested in over the years in many systems are both effects of sex and gender, and you saw some of these data on some of the other slides already, and in aging. Aging is a tricky thing, because if you want to study it experimentally, because buying aged animals is prohibitively expensive. So at the time we had 23 months rats as the old group and 3 months as the young group, and every single rat in the 23 months group cost about 10 times as much as a normal rat does. And obviously that's something that eats up a lot of your budget. And so we've already found is that there was an apparent decrease in receptor number, not in affinity. There was no shift in M2, M3, and there was no major change of contractile responses or subtypes involved in the contractile responses. By the way, you will notice that hardly any of my slides has p-values on it. And meanwhile, I became also the professor responsible for statistics teaching to graduate students in my university. And the more I look into statistics and talk to people who do that for a daily living, the less I like p-values. So the original papers all had p-values, but there's a long story behind that. Most professional statisticians these days will tell you, I wish we never had invented p-values. They get abused so heavily. So the conclusions on the physiology part would be that detrusor contraction, so detrusor is a smooth muscle of the urinary bladder, occurs largely via M3 receptors, despite being outnumbered by the M2 receptors by a 4-to-1 margin. Phospholipase C inhibitors and concentrations suppressing inositol phosphate accumulation had little effect only on contraction. However, there were strong roles of voltage-operated calcium channels and of urokinase. We did not observe major sex differences, and in aged rats, muscarinic receptor density was reduced, but no major differences in contraction responses or subtype involvement were observed. Let me come to the pathophysiology part. And I want to talk about 3 conditions. One is bladder outlet obstruction. It's mostly in humans a condition of older men. When the prostate grows too much, it constricts the urethra, and then urine can no longer freely flow from the bladder. In younger people or in women, it typically occurs as a birth defect, as a stricture, or other strictures in the urethra due to other medical conditions. The other 2 conditions we focus on were hypertension and diabetes. And these, other than generally being of interest here because both hypertension and diabetes are risk factors for the development of the most frequent bladder condition, which is overactive bladder syndrome. And I'll come to that a little later. So this slide actually comes from a study of my Dutch PhD student Maurits Barendrecht, a young physician, meanwhile a urologist. And because we hadn't established that model in the lab, I sent him for a few weeks to the lab of a colleague in Albany in the state of New York. And actually, although he was there only for like 6 weeks, the data he generated there while learning the model already led to a publication, which is the best of all worlds. You learn something and you get your paper. Anyway, what you see here is general staining for nerves, and if you quantify that, you can see that if you obstruct the bladder in a time course of just 1 week, you get a major denervation of the bladder. And normally, or very often, if a tissue gets denervated, it develops hypersensitivity to the most important neuronal transmitters controlling function of that tissue. And no one has ever found a major increase there. The spontaneously hypertensive rat may be known to many of you from cardiovascular research because it may be one of the most frequently used animal models of high blood pressure. But actually it's also a model of the overactive bladder. And again, we saw no major difference here in receptor density, affinity, or muscarinic receptor subtypes. And again, we checked the involvement of M2, M3 receptors, and role of rho kinase, and M2 receptors antagonize metoctramine only in very high concentrations in the 10 micromolar or more had major right shifts, whereas that the M3 antagonist darifenacin was considerably more potent. And again, the rho kinase inhibitor produced a strong reduction, and as seen in the earlier studies, both in potency and in efficacy. Switching to diabetes, and this slide really has absolutely no connection to today's presentation, except when I look through all my database of slides, it's the only slide that has the Czech Republic on it. And so I figured I must show that slide. Generally, when we think about complications of diabetes, we talk about the macrovascular, the microvascular complications that can cause major morbidity and mortality. Macrovascular complications, for instance, are coronary heart disease, myocardial infarction and stroke. Microvascular complications are neuropathy, retinopathy, and nephropathy. Nephropathy actually being the most costly complication, because as soon as that progresses, when a patient needs to get hemodialysis treatment because of the diabetic nephropathy, that alone costs about 100,000 euros a year in treatment costs. So it's a very expensive condition. And meanwhile, diabetic nephropathy is the leading cause of why patients need hemodialysis, actually. While all of these are really bad diseases, well, actually there is no good disease, but these are really bad diseases, alterations of the lower urinary tract, and including bladder dysfunction, are more prevalent than any of these. Certainly in the first few years when the other complications have not yet developed. So we did run a program on the bladder. This has nothing to do with the muscarinic receptors, but as a starter for a big program project grant on diabetes in the bladder, we actually did a systematic review, and it turns out that in all the animal models of type 1 diabetes, the bladder enlarges, typically a doubling. Whereas in the type 2 models, it's very heterogeneous, and whether that happens or not is not related to whether they're more or less severe in their diabetic status. And if a tissue doubles, that has a big effect. And similar to bladder outlet obstruction, diabetes, especially type 1 diabetes, leads to bladder denervation. So that was one of the theories why this hypertrophy may occur, which in turn means it could lead to hypersensitivity. In this original review, we already identified more than half a dozen studies having looked at that. And in the most frequently used animal model of type 1 diabetes, which is diabetes induced by a single injection of streptozotocin, STZ, depending on study, contractility went up or was unchanged. In the type 2 diabetes models, it was even less clear. If you look specifically as responses to muscarinic receptors, they were often increased in type 1 diabetes, and more limited data with purinergic agonists are quite similar. There was the observation that if you look at receptor-independent contractile responses, for instance, induced by potassium chloride, you see a similar increase in contractility. And there had been this hypothesis, well, there is an upregulation of the muscarinic receptor. Our big grant mostly really focused on the bladder hypertrophy and not on the functional alterations, but here's one study in the streptozotocin type 1 model, and we indeed observed there was some increase in contractility, and antibiotic drug reversed that, but to the same degree it happened with potassium chloride responses, which is indirect evidence that the increase in responsiveness has nothing to do specifically with the muscarinic system, but rather is a consequence of the overall contractile machinery working more harder. Here's a slide from a type 2 model of diabetes, which we induced by a combination of high-fat diet and low-dose streptozotocin, and again, a treatment group with an SGLT2 inhibitor, and you can see the curves are superimposable. By the way, the last slide in this is work of a PhD student from Ankara in Turkey, and I have a very close collaboration with this lab, and that was one of those projects we did cooperatively. So conclusion number 2 is that obstructed bladder, those from spontaneously hypertensive rats and those of many but not all models of diabetes, exhibit bladder enlargement to some degree. Sometimes this is accompanied by bladder denervation, and sometimes in this case means obstruction and diabetes. For hypertension, I'm not aware of such studies. However, there is no consistent evidence for denervation hypersensitivity specific for the muscarinic receptors. I don't know whether any of you knows or is aware of a British TV show, Monty Python. It was decades ago. And I'm not sure whether before 1989 it could be watched in Czechoslovakia, but they always had something on the show saying, and now for something completely different. So I'm switching now to clinical effects. I will, in this regard, talk about a condition called the overactive bladder syndrome. It's a syndrome primarily defined by the symptom of urgency. Urgency in turn is defined as a sudden, compelling desire to void that is difficult to defer. So if I was an OAB patient and had an urgency attack right now, despite giving this lecture, I would rush out of the door to the next bathroom in order not to wet myself. And you can easily see this is something really interrupting your life. In epidemiological studies, The prevalence of this increases with age in both men and women, reaching around 16% across all adult ages. Interestingly, and that has to do with the difference in the morphology or the anatomy of the lower urinary tract between men and women. In women, it is largely OAB with incontinence. In men, it's largely OAB without incontinence. You probably have heard that women are included in clinical studies less often than men, leading to major underrepresentation and thereby less knowledge on the treatment of women. And meanwhile, we know that for some diseases, the treatments mostly developed based on male data actually do not work well in women. So we have the good chance to look at some clinical databases in this regard. Generally, muscarinic receptor antagonists are a guideline recommended first-line treatment for overactive bladder, and until maybe 10 years ago, they actually were the only available medical treatment. We meanwhile also have beta-3 adrenoceptor agonists available. And around the time when these were entering the market in Germany, and most of these were in the early 2000s, companies launching their products ran large non-interventional studies with their specific muscarinic antagonists. And we were involved in more or less all of them as the lead investigators. So we had one study on darafenacin, and they are now in alphabetical order, with almost 4,000 people, 2 with propivarin, with 1,000 people by average, solifenacin about 4,000, and torteridine, one with 2 and one with about 4,000 patients. In contrast to all these other conditions, OAB, if you look at clinical trials, typically 80% of the patients are women. And you can easily see if women mostly have this condition with incontinence, if you have this urge but don't actually get incontinent, you suffer less and are less likely to go to the doctor to get a prescription. Whereas if you lose urine, then you're more likely to go to the doctor to get a treatment. So it ends up, despite the overall prevalence of the condition being very similar between the two genders, women make up about 80% of all the patients getting treated. Even the non-clinical colleagues probably are familiar with the concept of a randomized double-blind controlled study. What we did is something completely different. These are non-interventional studies, and you need to understand what they can do and what they cannot do to appreciate the findings. A non-interventional study systematically documents what happens in real life when a doctor prescribes a certain medication. Actually, whether the medication gets prescribed is not for study purposes. Just when a doctor decides, based on the symptoms and other characteristics, I want to treat this patient with this drug, only then they start documenting data. So there's no treatment decision involved as part of the study. Which of course also implies there's no control group. So no placebo, no active control. However, the placebo component in this condition is fairly high. And from whatever we see here, we cannot tell whether it's truly a drug effect or whether it's at least partly a placebo effect. However, from the patient's point of view, she doesn't care. She wants to get rid of her symptoms. So these non-interventional studies inherently cannot tell you whether a drug works. They can only be used for other things. They tell you what happens in real life. And because it's so much cheaper to include a patient in this trial, much greater patient numbers can be achieved. And if you have those large patient numbers, you are enabled to run multivariate analyses to compare treatment responses between groups because of the much bigger statistical power. However, that can become a double-edged sword in the sense that in a big database, a finding can have a low p-value but still be more or less irrelevant. So you really have to look is how big is the effect size. We used generally in all of these 6 studies, to look at the role of age, gender, and comorbidity with hypertension and diabetes to see how it affects treatment responses. And I will group the data by study and not by response. But you will see some recurrent themes across the studies indicating that they most likely are true. So this is the darafenicin study. And in the study we had non-diabetic and diabetic patients. The diabetic patients were older, were heavier, had been suffering from the condition average for a longer time, and much more frequently used co-medication because, yeah, when you're diabetic, you're taking anti-diabetic pills, hopefully. If you then look at control and diabetes patients here in white and black, the symptoms before treatment and after, you see that baseline symptoms were slightly greater in the diabetics and slightly greater after treatment, but the differences really are not that large. To get a better quantitative grip on that, we ran multiple regression models for these 4 symptoms. I'm showing you here the data for urgency, which defines the condition, and frequency, meaning how often a day do you have to go to the toilet. And we get somewhat heterogeneous responses even within a study. We see in both studies diabetes had an effect on the reduction of urgency and frequency. With age, despite the large patient number, the effect was seen for frequency but not for urgency. The gender effect was maybe seen here but not here, but the biggest thing was baseline of that symptom, implying it was to a large degree a regression to the mean phenomenon. To put this in perspective, the overall improvement was by about 4 urgency episodes and about 5 voiding episodes. And if you then look at the difference that diabetes makes to the worse, that's 0.5 and 0.6. So yes, in a big data set that has very low p-values, but frankly, that's a difference that an individual patient will hardly notice. That makes about 10% of the total response or less. And the same thing can be seen if you look at problem ratings before and after treatment. Again, control of diabetes shows no big difference. Turning to another drug, propivorine. I said 2 studies, and again, when we in the lab do our experiments, we typically use NS6, NS8, something like that. And we think that anything in excess of 10 is really a large sample size. As a statistician, I must say, I love your juvenile optimism. What you see here is 2 studies of identical design. One was run 2012 and one was run 2014. The design otherwise was identical, except for one additional questionnaire handed to the patients to fill out. And the effect of gender has a low p-value here, but not here. Even the age effect, low p-value here, but not here. And then a couple of other parameters. If we looked at the role of either diabetes, hypertension, or a combination of both, you see that how the scores can be shifted, and that's pretty much the same in all the conditions. And if you look at the improvement of urgency, incontinence, frequency, nocturia, again, they look very, very different. That's study 1, and in studies 2, it's basically the same thing. In solifenacin, we started out, actually that study was designed to look at primarily how the number of pregnancies, or actually deliveries, affects that. We know that women who have delivered a baby, except C-section, are much more likely to get incontinent. That is not due to overactive bladder, but mostly due to what's called stress incontinence, which pathophysiologically is something different. But still, we wanted to see how does number of deliveries affect outcomes, and had males only as a comparator grouping here. And if you just compare the males with the women never having had a child, which makes them the most comparable group to the males, you can see here that the reductions again for each symptom are very similar. Finally, a study on solifenacin, another antimuscarinic, and for that study we were mostly interested in the hypertension component, and all of these studies were run by urologists. And even though I work with urologists for more than 20 years now, I have limited trust how well they can measure blood pressure. That's just not their cup of tea. So in order to increase robustness, we used 3 different definitions of hypertension. We asked them to measure blood pressure, and you are at liberty to believe those values or not. We asked them, did the patient come to you with a diagnosis of hypertension? And based on what they had on the patient files, looked whether they had 1, 2, or more than 2 antihypertensive medications, indicating kind of a dose-response curve for the severity of hypertension. And what you can see here, looking at the reduction in urgency, incontinence, micturition, nocturia, and so forth, you see in the hypertensive group it's slightly less, again about 10% less, 60 versus 66. And that was basically true whether you looked at measured, diagnosed, or treated hypertension. But within the treated hypertension, there was at least a trend for a dose-response curve. Clearly with 2 or more, and more than 2 antihypertensive, they had the smallest improvement. Another study with the same drug, where we didn't look at diabetes or hypertension. Again, here, gender had a borderline p-value here as well. Here it has a low one for this parameter. Age in all sets had a low p-value, but some of the strongest effects were the baseline value of the same variable. In this study, we also looked at differences in tolerability. So, to put all of this together, my third conclusion is, based on large non-interventional treatment studies in patients with overactive bladder syndrome, only minor, if any, differences in treatment responses to various muscarinic antagonists are affected based on age, gender, diabetes, or hypertension. So this would conclude the scientific part of my presentation, but I have one more slide for the younger people in the room, and I take the privilege of an old fart to provide advice. What you could see about the study about phospholipase C, I think the deeper lesson here is dare to challenge unproven assumptions. I remember at one, you all remember from pharmacology textbooks, the adrenaline reversal based on administering a beta blocker, that the pressor effect turns into a depressor effect. We once did a study in humans on that, and we submitted that. The editor rejected it out of hand, saying, yeah, that has been in textbooks for 20 years. Where is the novelty? Said, I agree. It has been in textbooks for more than 20, 30 years, but we didn't find any human study ever testing that. All the evidence comes from dog studies. If you find any human study, please reject the paper. If not, please accept it. And after a week again, he said, you're right, accept it. So, challenging unproven assumption. I think that's really part of what scientists should do for a living. Second is always keep your eyes open for emerging opportunities. I'm not treating patients at all, but when I got first exposed to some of these large data sets, I said, well, maybe we can do something with them. The companies only wanted to brag like, oh, look how good our drug works, which always was scientifically flawed as a claim. And so I became, for some reason, an authority in this field clinically without ever having seen a patient by grabbing this opportunity when it presented. The final point, when I told you about this controversy with these colleagues in Philadelphia, collaborations can be great fun, especially international collaborations. For me, with a 40-plus year career in science, I must say, meeting colleagues all over the world, making friends all over the world, is the most rewarding part of a career in science. Of course, it can lead to lifelong friendships, which is for me personally the more important part, but especially for the younger colleagues in the room, that can often lead to interesting job opportunities. I've meanwhile worked in 4 different countries. Generally, one of the best things of the European Union is the Erasmus program, and which since some time is no longer only for undergraduates, but even PhD students and young postdocs can get Erasmus funding up to 12 months. And I strongly encourage all of you to look into that, because that can be a wonderful experience, not just scientifically, but in general life experience. And with that, my time is up, but I'll be happy to take questions.
Any question? Or I have one question, if I can. You mentioned that the outlet obstruction of urinary bladder lead to some degenerative changes of the innervation of the bladder.
Yep.
And does it mean that with, for example, prostate enlargement, the function of the innervation of urinary bladder will gradually deteriorate, or
That's a really interesting question, and you know what? I don't think anybody has ever researched that. Because as long as the patient lives, it's really hard to get a piece of bladder, especially from the outer side where all the nerves run. And that may need to be a post-mortem study. I think the question is really good, and I never thought about it. But to my knowledge, nobody has ever investigated that. The phenomenon of the denervation in animals has been found by multiple people. But very interesting question.
Are there any other questions?
Okay.
If there are no questions, thank you very much. And it was quite interesting lecture. I have never heard about this topic before.
Yeah, bladder disease is a niche indication for most pharmacologists. That's very clear.
Thank you. Going to close this lecture.
Time to have beer.
Yeah. Better part.
Okay.
So there are at least some studies detecting them. But clearly, MR. Protein, I've not seen any study even looking for that. Because and 2 is about 80% and 3 is about 20%. The thing is, everything else together is so limited that detecting that at protein level, you would need some really very, very selective which I haven't seen yet. Yeah, but yes, but for that, if your Q&B signal is 98% M2 and finding the remaining 2% is technically, I don't think you can do that. And there is a methods book that talks about that.
Okay.